Welcome, everyone. This is going to be the final session for this year's IKCS. Definitely want to thank the organizing committee for putting this all together. And there'd be no, I think, more poetic way to end the meeting than discuss the major impact that the COVID pandemic has had on everyone this year, including all of us working in the GU kidney cancer world, but also importantly, our patients that we care for. I'm honored to be joined by an esteemed panel, and it's well represented as we have a patient in Megan Connolly, and we have surgeon representation, and we have a lot of East Coast representation here, which makes very good sense with how hard the East Coast area was initially impacted by this pandemic early on. Our goal is to really think about some of the lessons that have been learned in the early management of the pandemic and how we can all be prepared as this pandemic continues to gain traction across greater swaths of the country and is really showing no signs of slowing at this time. And so with that, I'd like to introduce my colleague and co-lead of this panel discussion, Dr. Bill Wong from EU.
Thank you, Matt, and thanks everyone for participating in this event this afternoon. Just as a reminder, all of the speakers today for this session have pre-recorded talks, so you can definitely go back and listen to their complete presentation in greater detail after this session's over. So I want to just briefly introduce the panel today. As Dr. Campbell had mentioned, we have a panelist who is an actual patient, Megan Connolly. We also have medical oncologist, Dr. Martin Voss from Memorial Sloan Kettering. And then we have two urologic surgeons, Dr. Schinder and Dr. Srivastava from Rutgers Cancer Institute. So I think to begin the session, a great way to introduce this would be to get an idea from the participants how the COVID pandemic has affected everyone, both from a patient standpoint as well as a provider standpoint. So we have a couple polling questions that we can begin with. I don't know if everyone can see on their screen the polling questions.
Yes,
but great. Okay, so I'll start with the first one, and this is for the patients in the audience. As a patient, do you feel that the COVID pandemic has affected access to your treatment or delayed your diagnosis in some fashion? A would be there's been no delay or access to treatment. Somewhat delayed would be B. C would be significantly delayed. And D, I have had no ability to access or care or diagnosis since the pandemic. So we'll give a few minutes for the remaining people to answer. And it looks like indeed, from a patient standpoint, there has been somewhat of a delay in access for either the treatment or a delay in the diagnosis. The second question, also designed for or addressed to the patient, do you feel that the COVID pandemic has negatively altered your kidney cancer outcomes? A, answer being it has not had any negative impact. B, it somewhat has had an impact. C would be it significantly has impacted my outcomes. And then the final would be it has dramatically altered or completely altered my outcome. in just a few more seconds. I feel like I'm looking at the electoral map here. Okay, so it looks like for a good number of patients out there that it has not altered their kidney cancer outcomes in any fashion. And primarily the remainder saying it is somewhat altered, but it's good to see that it's only been a few people out there who have felt that it has significantly negative altered their kidney cancer outcomes. Okay, so we can move on to the third polling question. This is for the providers, for the physicians. And that would be, has the COVID pandemic resulted in some significant delay in diagnosis or treatment of your patients? So this is essentially the same question, but we want to see from the provider standpoint whether they feel that this has had a dramatic impact on access to providing care or diagnosing their kidney cancer patients. So again, for the providers, do you feel the COVID pandemic has negatively impacted the delay in the diagnosis or treatment of your patients? A, with none of the patients being affected, B, a few, C, a significant number, and then D, nearly all my patients have been affected. So again, I think that's been a good enough time. It's encouraging to see that as providers in general, the consensus is that only a few or none of the patients have had a significant delay in diagnosis or treatment of their patients. But at the same time, it looks like about 15% of people or providers did feel that there was a significant impact or have been completely negatively impacted by the pandemic. And then finally, we can move on to the last polling question, which again is for providers. And that is, has the COVID pandemic resulted in worsened oncologic outcomes in your patients? Again, A, with none of your patients being having worsened oncologic outcomes due to the pandemic. B, a few, C, a significant number, and D, essentially all or nearly all of your patients have been negatively impacted. All right, so it looks like in this situation, it's good to see that, particularly from the provider standpoint, that there were really a few providers who felt that their patients had worsened oncologic outcomes. Obviously, this is slightly different than I think from the patient perspective. So I think this will be a very interesting session to see how the pandemic, or at least the impression of how patients' care have been delivered and how their outcomes have been. So I think with that, we can go ahead and get started with the session. I'll have Dr. Campbell introduce our first speaker, which is Megan Connolly. And we have a couple questions for her regarding her experience through this pandemic.
Yeah, and so as Bill brought up, I would highly encourage you to watch Megan's presentation. It's very moving for her to describe the journey that she has gone through to get to this point today. Megan is a little bit under the weather, and so we may have to have a couple of brief breaks if needed, just to make sure that her voice stays strong. But, one of the things that I really, took away from your presentation was the role of telemedicine that has changed pretty significantly during the era of COVID. And you discussed that you received your initial suspected diagnosis over the phone. And I wanted to get your impression about, and if you could describe for us again your experience with getting your initial diagnosis over the phone and how that went as opposed to how you could imagine it being in an in-person setting.
Sure. Well, thank you, Dr. Campbell, and thank you, Dr. Huang. Apologies for my voice. Ironically, for the COVID panel, I fell sick this week with a cold and lost my voice. But I think, your question about telemedicine. So I actually received the phone call. This was pre-COVID. So my urologist didn't call me because of COVID situations. The COVID situation, it was just, I guess my results from the MRI report came in at the end of the day. And so he called me as he was leaving the office. But I would say, there's two parts. One, I think the telemedicine piece, once COVID hit, it's actually been great. I think for some patients, it's probably improved their ease of access to physicians. I mean, if you think about it from a patient's perspective, and I think about myself here in Florida, I ultimately ended up going to Washington, D.C. To see a urologist for a second opinion. If we were in the midst of COVID at the time when I was having that initial appointment with him, it would have been done via telemedicine. And so I think patients are going to have more options if we continue in this trend of telemedicine, where I don't have to go with a doctor that is where I live, a local doctor. I can have more access to doctors, in other places of the country. So that's a benefit of telemedicine. My experience with the phone call, like I said, it wasn't because of COVID. It was just because of the time of the day. But I will say, and I mentioned this in my pre-recorded remarks, that when you hear the words "you have cancer," everything around you freezes, and it's like there's a moment of silence and nothing is moving, and it almost it's a very surreal feeling, like this can't be true. There's something I kind of just thought about after that experience with the doctor that gave me my results was, I think it's very easy for us as humans, as professionals, to become desensitized with, things that we do on a daily basis. And I think sometimes for doctors, you can forget that phone call that you're making or that appointment that you have, like that is the most important moment in that person's life. Like that is the most stressful moment in that person's life. And while it might just be another day at the office for you, it's very important for you to have compassion for that patient. And, the call that I had, it was the total opposite. It was very much, it was a rushed phone call. It was a phone call that I knew he wanted to get home and his day was over. And, I think just as humans, it's important to just be compassionate, especially, when you're giving patients a diagnosis like cancer.
Thank you, Megan. And you then were having to make a decision in terms of surgery. And I understand you had the decision if you were going to have the surgery potentially locally, or if you were going to decide to go with the place where you had your second opinion. And from my understanding, this was during at least the beginning of the pandemic. How was that weighing on your decision at the time?
So it definitely was a stressful part in making that decision. I had the second opinion in February. I had my biopsy in February in DC. So this was actually kind of pre like COVID. It was when I received the results of my biopsy that I had to make an appointment. And this was in early March. So it was kind of as COVID was becoming it was gaining some traction. People really weren't sure, where it was going to go, if it was going to have as much of an impact as we had seen in other places in the world. And I made my appointment for my surgery appointment for March 31st. And in the weeks leading up to that appointment, I mean, I was speaking to my surgeon on a weekly basis to get updates on what the status was. And, if you think about it, during this time, this is when we saw a lot of COVID cases in New York City, and we saw how the hospitals were managing that situation. And I was headed to DC. And so DC was preparing to kind of be the next hotspot. And so there was one week where the hospital that I was going to have my surgery at, there was discussions, whether or not that was going to become a COVID-only hospital. And so there was no guarantee that my surgery was going to happen up until 2 days before it actually did.
And then I think the kind of the final follow-up is, our down at MD Anderson, and I think at many centers across the country, we're very much limiting caregivers to be able to be present in the hospital, trying to limit number of potential exposures to hospitalized patients. Can you kind of walk through your experience with having to go through a major surgery and then having to do recovery with your spouse in the city, but not able to be by your side, and how that was for you?
Sure. It was very difficult. And I don't think anybody realizes how much how important family members and loved ones are when you're in the hospital and just part of your recovery process. I mean, when I arrived to the hospital that morning for my surgery, it was standard. You go through a series of questions, let you in, give you a wristband. And I went into the waiting room, and typically I'd had a surgery previously at this hospital. I mean, the waiting room would be very busy, and there was, myself and maybe 8 other patients waiting for surgery. And, I went back into the pre-op room, and, I was told I needed a COVID test before I could proceed with having my surgery. And this was right as they were, I think, kind of in the beginning of the COVID test. And I remember I went into a back room, and they administered it, and I waited a couple of hours to get the results, and I was able to proceed. But then after I got out of surgery, I was on my own in the hospital, and I ended up staying there for a longer period of time because I had a couple of pseudoaneurysms from the surgery. And so I just remember being in my room myself, the nurse telling me that I needed to walk, and I tried to get out of bed, and I mean, you're in a lot of pain. You feel like you're off balance. You feel like you're going to fall over. And I knew, and I didn't expect the nurse to help me to walk because they were minimizing contact with patients. So I requested a walker, and I used a walker to do a little bit of walking, but I was afraid to leave my room. I didn't want to walk down the hallway. I was afraid about being exposed. The doctor would come in and check on me. His residents would come in and check on me. They'd ask me questions. I'm under a lot of medication. I'm trying to, remember what they're asking me, and those are all situations where you would rely on a family member to be there for you, to help you, encourage you to get out of bed, help you walk, help talk to the doctor, remember what they said. And so actually one night I was on the 5th floor of the hospital. I knew what side of the building I was on, so I turned the lights out. I called my husband. He came over. He counted the windows up to the 5th floor, and I flashed a flashlight down to him from my phone, and he was able to wave to me. And it was just nice to be able to see him when you're isolated in a room for yourself. or by yourself for a week. So it was definitely hard.
Megan, thank you very much for sharing your story with us. And as we're going to try to preserve your voice, we'll definitely come back as this session continues to go on. Bill, do you want to introduce both Brian and Arnav and discuss their excellent presentations from the surgical perspective, working under Dr. Singer?
Sure, absolutely. So our next group of speakers will be Dr. Schinder and Dr. Shrivastava, who are really going to talk about how their experience was in terms of handling the management of the surgical patient with the diagnosis of kidney cancer, and how they prioritized their resources and how they actually chose patient selection as to who should go on to surgery and who could wait. And I think this is going to be particularly relevant because a lot of us, particularly on the East Coast, like in New York or New Jersey, sort of went through this wave already. But if you think about it, it actually is far from over. So I think there's a lot of lessons to be learned. And I think we can start with Dr. Schinder. If you could just describe to us sort of your experience or your medical center's experience and how you prioritize resources, what resources you wanted to preserve and make available, and what were your lessons learned, if you could say that, from the experience?
Sure. Yeah, I mean, so the first time it kind of came up, I remember it was right as everything was starting to kind of explode, you know, so to say, in the New York, Northern Jersey area where we are, late February, early March. I remember in the operating room doing a kidney cancer operation, and there was some rumblings from our colleagues in New York that some of the hospitals were going to be stopping, you know, quote unquote, elective surgery. I remember being in the operating room and we were talking about what that means because we were doing a cancer operation. And while, you know, one could argue that it is, you know, it's not a trauma surgery, it's not an emergency surgery. You know, there's certainly in the vast majority of cases, there's nothing elective about a cancer operation. And so we started to think about, you know, what that would mean if they canceled, you know, if they or limited elective surgery at our hospital. What would that mean for, you know, for cancer operations, for kidney cancer operations? And sure enough, as things sort of got worse in our area, our hospital and, you know, our healthcare system, and then the state of New Jersey put a limit or a mandate to halt or to significantly limit elective surgery. So at our institution, certainly trauma cases were, you know, life-threatening cases were did proceed. For cases that were being booked from the outside, so for example, kidney cancer cases, essentially they had to go through a review panel of some administrators, some, you know, chairman of the surgical department, to say that it was essentially worthwhile or worth it to use the resources that you would need to undergo that operation or to perform that operation. And they would, you know, look at the availability of those resources in the hospital and say, would it be allowed to proceed? And so it was tough because the busy tertiary referral cancer center, there's plenty or a lot of operations to perform, and we're sort of left in a situation or put in a situation where we had to pick out the most severe or advanced cases to proceed with.
And I think along those lines, that's a great lead-in for for a discussion about Dr. Srivastava's project looking at patient selection and sort of choosing which patients should proceed with surgery, particularly during that time frame, and whether or not a delay in surgery could negatively alter outcomes depending on the patient who presented with a kidney mass or a kidney cancer. So could you comment on that?
Yeah, sure. Thank you. Yeah. So, really, when we were sort of in the process of triaging patients, there were really sort of three groups of patients that we had to think about. So the first group are patients, with small renal masses, 2 centimeters. And, for that group, we sort of know from very good prospective active surveillance literature that most of these masses can be safely watched for months, if not longer. So, when we were calling the hospital to, to pick which cases we could do or not, we knew that those cases could sort of be safely deferred, as long as we had good patient follow-up and good mechanism in place to make sure that the patients get their treatment or surveillance as they need. On the other end of the spectrum, we had more advanced cases, so patients who might need a cytoreductive surgery or who have locally advanced disease with things such as tumor thrombus. Those cases obviously are a little more urgent because their tumor biology is more aggressive, and those patients need to go to surgery. And while we had to work within the constraints of the pandemic, the urgency of the oncologic portion of their overall healthcare was urgent enough that it was very clear that those patients needed surgery. The kind of problem of ambiguity really arose between the patients in the middle, the third group, and that's T1B to T2B masses that were localized to the kidney, but larger than your traditional small renal mass. So we use the National Cancer Database to sort of address that middle population and understand how surgical delay might affect their outcomes. So, based on our center's experience in most of the East Coast, our patients experience delays of, 1 to 3 months, and that's sort of how we set up our study. You get your surgery, quote unquote, immediately, less than 1 month after diagnosis, 1 to 3 months after diagnosis, or greater than 3 months. And we sort of looked at two endpoints. The first endpoint, which we looked at in lieu of cancer-specific survival, which was not available by the NCDB, was PT3A upstaging, and our second endpoint was overall survival. And what we find is that actually for the majority of these patients, those patients who had delayed surgery up to 3 months and possibly beyond based on a sensitivity analysis, they did not appear to have compromised oncologic outcomes. So, while we would never, sort of push for delaying these surgeries, obviously, I think our study was reassuring that that in the constraints of the COVID-19 pandemic, delaying surgery for 1 to 3 months would not necessarily compromise survival for the majority of these patients.
As an aside, and I think an interesting question to ask, because I'm sure you had to deal with this as we all did in early March or late March, early April, was how did you go about explaining to the patient, particularly the one who was just recently diagnosed with a large localized tumor? Well, we think it'll be okay. You could probably wait. And if there was resistance or pushback, how did you deal with that?
Yeah, so I think that, there's sort of a couple things in play. So I think number one was really trying to sort of explain to the patient that part of your treatment is absolutely optimizing the way we treat your cancer. So treating it promptly and treating it efficiently. The second part of it is that is sort of communicating that that the hospital is not the safe place that you thought it was a couple months ago. One of the hospitals we go to was up to 80-90% of the patient population was COVID positive. And, what we had to explain to our patient was that, that while we want to treat your cancer as effectively as possible, we have to do it within the, within the constraints of a healthcare system that was sort of figuring it out as we go. And then also, if we bring you into surgery, we treat you fine, and then now we have to deal with the concept that while you're recovering from your surgery, there's a decent chance that while we're still trying to understand the virus at this time, that you could contract COVID-19 on top of your surgical recovery as is. And are we actually doing a disservice to you by rushing your operation? So you're thinking critically about your care, I think was a message that was pretty fairly received by patients, by the hospital, and by the providers we collaborated with.
Great, thank you. Dr. Campbell, should we move on to Dr. Voss?
Yeah, so Dr. Voss, I really enjoyed your presentation. I thought it was a fantastic 10,000-foot overview of your experience at one of the busiest cancer centers by far in the world in managing COVID. And so I really like to take you through your presentation because you talked about outcomes of patients with cancer who have been infected with COVID. And you also started delving into treatment selection and if those were potentially influenced by COVID. So I'll give the floor to you. Thank you.
Yeah, thank you so much. Can you hear me okay?
Yes.
Thank you so much for the invite to present and for being part of this panel today. So I was asked to speak to the impact this has had on, maintaining our care for patients with metastatic disease, particularly those who are under systemic therapy with us. And there's so many facets of this to go through. And it took me quite a while to figure out how to best approach the presentation. But if you have the chance to look through it, it essentially has several sections. First, speaking to the pathophysiology or maybe the clinical course of COVID and how much we know about it in cancer patients specifically. The presentation I recorded not too long after the ESMO presentations that had given us updates from large registries in the US and in Europe. So it gives a bit of an overview in terms of the data that we have for our cancer patients. And I'm not going to go through all that in detail now, but I think the key take-home messages for me from what we know about the virus and cancer patients is, number one, undoubtedly, cancer patients, so our patient population, are at increased risk for adverse outcomes if they do contract COVID-19. So the risk of hospitalization and mortality from COVID is higher than the general population. But we have learned through the months that there's no clear signal that the treatments we administer to treat particularly kidney cancer raise the patient's risk substantially beyond that. Which is something that was completely unclear at the time that the first wave hit us here. But from the registry data that we have and the analyses that have been done on various continents, it is not clear that patients, through initiating systemic therapy, and that includes the various subgroups of therapy, notably increases their risk for adverse outcomes. Now, there's limitations to how that can be addressed and limitations to what the cohort sizes allow us to do in terms of looking at TKI therapy versus immune therapy and so forth. But it is noteworthy that so far none of these analyses with larger registry data have convincingly suggested that we put our patients at increased risk for COVID adverse outcomes by leaving them on therapy or starting them on therapy. And then thirdly, very clearly, and by measures of common sense, metastatic cancer does not wait. and there is a need to make sure that we continue to treat our patients and that we treat them well. The experience that we had here in New York City through March, April, and May, of course, was unique, and I don't have to go back and remind all of you, what just happened, what happened here. And you heard from my surgical colleagues before that certainly, shared this experience with us. But what was different when we went through this was that this transition that we had to undertake was certainly less well controlled than it might be for other metropolitan areas that went through this in the summer or are going through it now. What I mean by that is New York City was hit suddenly and massively without proper testing available to the individual hospitals, without really knowing any of the data that we have now in terms of how the virus may affect patients' outcomes on therapy, off therapy, and so forth. And then thirdly, the best data we had, or the most recent impression we had, was what had happened in Italy, which certainly struck fear in everyone, here in the healthcare system. So within a week or two, we completely changed our treatment algorithms here for patients receiving systemic therapy, in that the medical oncology patients had to be kept on therapy, but exposure had to be minimized. Infection rates were extremely high in the city. Access to inpatient care was affected in massive ways by the fact that a large proportion of inpatient beds, growing sort of day by day, week by week, were absorbed by those in need for acute management for COVID-19. We also had to find a way to keep our staff safe. Thinking back to these days, and also hearing Megan's presentation before, I've been just so impressed by how our patients have managed all of this. And that still is the case, going from what used to be, near 100% person-to-person encounters to, over 90% remote encounters within a time span of 2 weeks. That's the data. If you look at the Sloan Kettering's data from March and April, you would think, must have, massive impact on patients. And the anticipation, we didn't really have time to think about it, but looking back, I would have anticipated that there'd be a lot of pushback from patients, but our patients were just wonderful in, going with it. And whatever we came up with, and we changed our approaches really, several times a week, they would put up with it and would be grateful while they did it. It was really, scary times, but it was such a good experience in some ways. So just, having patients put their trust in us, remotely, waiting for hours for that clinic visit by phone. We were so inefficient in the beginning when we switched from in-person to remote care, and then having that patient who had sat at home for 4 hours to wait for my phone call, be so thankful when I would speak to them, was just motivating, and just ways that I hadn't quite experienced before. And the same for our staff. Everyone, not only the physicians, had to change their ways, had to go remote, at the same time, have their kids go to, homeschooling, and, accommodate the off-hour phone calls we were making to all of our patients. And our administrative nursing care, our research administrator, everyone was chipping in, and it was, a good experience that way, despite of everything. I think a big question that came up early, and that I'm sure comes up for many other sites now, is what to do, particularly in kidney cancer patients, with decision-making about, the various therapies that are available to us. At this conference, we've talked to no end about choice in systemic therapy and the option to treat with IO versus IO-TKI. And again, I think it's different how we approached this during the first wave, not knowing really what the impact of things were. For instance, there was a great deal a great deal of concern that immunotherapy may augment the inflammatory effects of COVID and may put patients at increased risk for outcomes from a pulmonary perspective, which is something we ended up not seeing, but we just did not know in the beginning. So there were a lot of questions as to whether someone who was on therapy already should be taken off and switched to TKI monotherapy, or whether someone who was, in need to start first-line therapy should do so rather than go on an immunotherapy-based regimen. What about treatment intervals? So going from every 2 weeks to every 4 weeks on nivolumab, is something that had been established through FDA label expansion long before then. But if you remember, the expansion of the pembrolizumab label from every 3 to every 6 weeks actually came through as all of this was unfolding, which was like a godsend to us, because we could argue to patients, okay, we have to bring you in and out of the healthcare system less frequently. If I look back at all this now and think about how I practice now and how I make decisions for my patients, then I personally would say 2 things. For one, I do not think that COVID rates should be a major decision maker in terms of thinking about adverse effects of our treatments or the effectiveness that a treatment can have for our patients. I don't see data that speaks to it putting the patients at higher risk. I've said that before. So I think we still need to think about the best way to treat the patient's cancer, particularly now that we have workflows in place that can make this safe. But secondly, and very importantly, I've always been a strong believer in shared decision-making with my patients, but it becomes also more important to listen to our patients and understand how far away are they from the infusion center, how scared are they to leave the house, what type of support do they have to go back and forth. And that does go into decision-making always, but maybe, it should go in these decisions more so now. We've worked through ways to make remote care work for patients receiving oral and IV therapies. When we switched to remote care, going from in-person visits to remote visits, initially most of it were phone visits because we didn't have the technology in place, we didn't have the expertise, we couldn't quite coordinate it, and it took us the better part of a month to switch to mostly video visits. And I'm sure all of you have had the experience that video, even if it's blurry and from a small screen or a handheld phone, adds so much to just doing a phone visit. And it's just so helpful. I often, see a patient remotely, and my nurse or my fellow has already talked to them by phone, and they're really concerned and we're not sure how the patient is doing. Then seeing the patient, just seeing how they look, adds so much to understanding what's going on. And oftentimes the first 3 seconds, I see the patient on the screen, I have this sigh of relief because I can see, no, they're doing okay. It doesn't look, even though I don't do a full exam, right? There's something about seeing the patient talk and move and interact with you that can tell you a great deal about their performance status. We've learned to do remote physical exams, as I'm sure all of you have done. For my TKI patients, I have them show me their hands to look at, look for calluses. I have them, show me their feet. With a phone, we can look in their mouth. There's a lot of stuff we can actually do, which wasn't so, apparent, that helps, manage our patients right. And then most importantly, you can interact with the patient. All of our patients are on some level longing to see us in person, but all of them are on another level very scared to come in. Sort of keeping that balance has been kind of tricky. We went to, I told you, 80-90% remote, and at this point, we're probably about 50-50. A lot of patients have learned to appreciate remote care. I think Megan made that point before, and it is easier in many ways for some patients. So I think it's going to stay to some level. But most importantly, it's provided us with the means to give patients high quality therapy for their metastatic cancer. The last 2 things I want to talk about briefly, I'm sorry to take so much time. Number one, research. So our research apparatus obviously, went to a near standstill during March and April. But remember, we had patients on trials, and not few of them, and had to make that work. I was pleasantly surprised by how flexible sponsors were. So we were given right away a lot of leeway without an exception, from all the sponsors that work with us on trials to make remote visits work, with the proper documentation, be able to do all these protocol deviations that we did to ship investigation product to a patient's home, to have them come in less frequently for what we felt may not have been necessary visits from a clinical perspective. We've learned to do remote consents, once things started to run again and we thought about bringing patients onto trials. We can do a lot of it remotely over internet. We always see patients in person when they start on a clinical trial, but a lot of the upfront work can be done remotely. And then the last piece, which I think is also very important, and what's difficult to fit in the beginning, is education. So we not only care for our patients, we also train our residents and fellows that come through our clinics. Going all remote or nearly completely remote, of course, was really hard on them. They have limited amount of time to learn while they go through fellowship training. And it's important, I think, for all programs that haven't thought through this yet for what's to come, because I agree there's more of this, not less, to think through ways to integrate fellows into clinic workflows, be it remotely, be it remote from the patient, yet side by side with the attending, or be it in person for those patients who come in. It's worth spending some time to think through. Surely it took us a little bit of time, but now I think we have workflows figured out for that also. That's my monologue.
Thank you, Martin. No, that's fantastic. And again, I highly encourage everybody to watch the whole presentation because it really is comprehensive. And I think there's a ton of lessons that we can all learn as this pandemic continues to range on, from centers that went through the experience first, in terms of having to really reshuffle the deck to make sure that patient care and research was able to continue on. We're getting very short on time. And so I would like to, again, thank all of our participants on this panel. Megan, thank you for sharing your story with us. Brian and Arnav, congratulations on fantastic work. And Martin, again, thank you very much for spending all the time with us and for putting so much effort into sharing your experience. And Bill, again, thank you very much for co-moderating, and like to thank everybody for attending the IKCS this year. I think this was a tremendous meeting, and Joe and Eric should really be commended for their hard work. I think we may have been kicked off.
That's my bad, guys. Sorry.
No, not at all. Either way, thank you everyone for participating, even if it's just you guys who can hear us. But they were really great recorded sessions and really great talks, and really appreciate participating.
Yeah, Martin, that was fantastic.
Yeah,
your presentation was tremendous.
Very comprehensive.